Silk, Smooth Incision Lenticule Keratomileusis. Its unique cutting-edge technology combines shortest pulse duration, smallest spot size and tightest spot placement, which enables a bridgeless corneal resection for a very smooth and a fast recovery. Benefit of Silk is mainly due to the minimal incision of 3 mm, which leaves cornea stronger and less dry eye. And its other advantage is the unique biconvex shape of the lenticule, where cornea does not collapse more, thereby giving a better and faster recovery of vision. With our initial cases, we learned that marking the visual axis and the visual center under the microscope before the procedure helped in better centration and cyclotorsion adjustment for the best visual outcomes. Sometimes while docking, eyes may be decentered, and repeated docking leaves an oily film on the PI. This oily film can hamper the laser firing, especially at deeper planes as required in lenticule making. Thus, using a new PI at such times can be really helpful. This was one such case of uncut lenticule when on retrospecting we observed there were multiple docking attempts made. Fluctuation in temperature was also noted. This was planned for a PRK after complete healing and stability of refraction. While in your learning curve, keeping the entry wound to about 4 to 4.5 mm initially can ease the dissection maneuver and prevent tearing of the edges of the wound. This width can gradually be brought down to 3 mm once we are comfortable with the surgery. Similarly, entry to edge extension can also be increased by a few millimeters to give more space while finding the anterior and the posterior planes. Most important is finding the right plane. Here we have made an entry wound of 4 mm and increased entry to edge distance by 0.2 mm to make more space for the maneuvers. Now, knowing that our lenticule is a biconvex, while entering the anterior plane, the dissector is directed upwards, slightly tented up, and given a wriggling moment. This separates the edge and then making a pocket in the anterior space and stopping till midway. To find the posterior plane, we start from the extreme right, dip in a little and open the pocket beyond the midway, overlapping the pocket of the anterior plane. Here, when we swipe beyond the midway and still feel the resistance, we'll make sure that both the planes have been dissected. Here we see again entering the anterior plane with dissector upwards, stopping at midway, dipping and entering the posterior side of the plane, swiping beyond the midway and feeling the resistance, making sure that we have entered the other side of the lenticule. The other way to determine the plane is by making cut edge of the lenticule as a guide. This mark is clearly visible on top of the dissector when entering the posterior plane, whereas this cut edge mark is not visible if entering the anterior plane because dissector is above it and covering it. We can also use opaque bubble layer to our advantage. Visibility of the dissector is more when in the anterior plane, whereas it reduces when in the posterior plane due to a layer of OBL over it, thereby reaffirming which plane we are in. Even when the planar dissection is complete, never force pull the lenticule in case resistance is felt. It may leave uneven edges or tags behind. removing in a circular motion will give a gentle force and prevent uneven tags and edges. Few minor things make all this process far easier, like using a good holding forceps for better dissection, keeping the surface moist for more clarity, and a good microscope for increased depth of focus and a good visibility.